Today I'll share our work using mathematical modeling to examine mass incarceration as a driver of the tuberculosis epidemic in Latin America and project future impacts of policy alternatives. And before I start, I also want to acknowledge that I currently live and work on the occupied lands of the Quinnipiac, Wappinger, and Pagosset peoples. But the work that I'll share today was actually done during my PhD at Stanford University, which sits on the occupied and unceded lands of the Muwekma Ohlone people, who continue their decades-long fight for federal recognition. And I express my personal commitment to an ongoing process of learning and supporting Indigenous sovereignty and efforts to promote justice and reconciliation. All right, so tuberculosis has been and continues to be the leading cause of infectious disease deaths globally. And over the last 200 years, it's claimed over 1 billion lives, more than any other infection. And today, despite the existence of highly effective antibiotic treatment regimens, over 1 million people continue to die from TB each year. And the burden of TB is highly unequal in its distribution. So it disproportionately affects people living in poverty in low and middle income countries. But also persists in pockets in high-income countries of highly marginalized populations. And the social and structural drivers of TB go far beyond simply access to care and even health system capacity. And we can see this by looking at history. So in this figure, we're seeing death rates from TB in the UK in the 1900s. And you can see that the majority of the decline in TB mortality actually came about before the discovery of the first TB drugs in the 1940s. And what this suggests is that dramatic progress in TB control was achieved and is possible through transformation of these social and structural factors. And accordingly, I think it's more accurate to say, rather than TB killing 1 million people each year, that systems of global inequality and injustice and the lack of political will to change these systems kill over 1 million people with TB each year. So in 2015, the World Health Organization launched the NTB strategy to really accelerate progress towards TB elimination worldwide. And they set these targets to achieve 20% reductions in TB incidence by 2020 and 50% reductions in TB incidence by 2025, relative to the 2015 rates. However, by 2022, globally, TB incidence had only declined by 9%. And this was in part due to the health system's disruptions of the COVID-19 pandemic, but even before that, we were pretty off track. Even more alarmingly, though, in Latin America, TB incidence increased by 19% over the same period. Now, concurrently, Latin America has the fastest growing prison population in the world. So this figure is showing the percent change in the prison population across different global regions since about the year 2000. You can see that the rise in incarceration in Latin America really outpacing population growth and outpacing any other region in the world. And this trend, while driven at the absolute level by Brazil and Mexico, has also really been seen across nearly every country in the region in Central and South America over the last few decades. Now, we know that this will probably have dire consequences for TB. So recent systematic review and meta-analysis found that globally, the risk of TB is 10 times as high in prisons as it is in the general population. But this disparity is really magnified in South America, where the relative risk is nearly 27. So TB risk nearly 26 times higher in prisons than in the general population. So where does this elevated risk come from? Now, first, we know that people who are incarcerated disproportionately represent kind of marginalized populations even prior to their first incarceration. So they may present with a higher prevalence of other known TB risk factors that can then be exacerbated during their incarceration. Things like HIV, smoking, drug and alcohol use, and mental health conditions. Once they are incarcerated, they are then exposed to conditions and the experience of incarceration, including overcrowding, poor ventilation, malnutrition, and barriers to accessing medical care, which not only foster transmission of TB, but also increase the risk of progressing to disease. And so what is the contribution of kind of the pre-existing vulnerabilities versus the experience of incarceration? A prior study in Brazil really tried to answer this question. They followed a cohort of people who were newly incarcerated for the first time and found that their TB rates, shown here in the blue line, were really quite low, comparable to the general population at the time of prison entry, but really dramatically increased with increasing time incarcerated. And conversely, following release from prison, their risk of TB declined, suggesting that at least in Brazil and similar epidemiologic settings, the high risk of TB in prisons is largely driven by the prison environment rather than these underlying kind of pre-existing vulnerabilities. And so as incarceration rates have increased across the region in Latin America, what has happened is that TB across the region at the population level has become increasingly concentrated in the region's prisons. So here I'm showing you figures on the x-axis is year and the y-axis is the percent of all reported TB cases that are occurring among people deprived of liberty. And you can again see that in nearly every country, that proportion has been increasing over time. And region-wide, it reached over 11% in 2017, more than doubling from 6 years prior. And this gives us a sense of, the proportion of the TB epidemic that might be occurring in prisons, at least among reported cases in prisons. But this percent, 11%, likely is still an underestimate of the true contribution of incarceration to the TB epidemic for several reasons. So first, the percent of all cases that are actually diagnosed and reported in prisons is estimated to be much lower, only 53% compared to the general population. Second, TB is a really slowly developing disease, taking months to years to progress after exposure. And this combines with incarceration being a dynamic risk factor, such that individuals who acquire infection in prison may not progress to disease until after release from prison. And you remember this from the previous slide, showing this elevated risk of disease for up to 7 years post-release. Now, currently, routine TB notifications databases don't collect information on incarceration history. And therefore, these cases that are occurring in the community after release from prison are not attributed in any way to incarceration. And finally, we know from genomic epidemiologic studies that have looked at the relationships and closeness between bacterial genomes that infections acquired in prisons can spread in outside communities, including to people with no history of incarceration. And here is an example of a genomic cluster of the Mycobacterium tuberculosis that spans patients with and without incarceration history, showing that these epidemics in prisons and communities are highly interconnected. So for all of these reasons, the full contribution of incarceration to the TB epidemic is likely much greater than had been previously recognized. And why do we need to understand the full contribution of incarceration? So since 1997, the WHO has published a global TB report every year, which really serves as this guiding document for national TB programs, for donors, healthcare providers, and researchers worldwide. And in 2017, recognizing the need to address interrelated social determinants in order to end TB, the WHO Global TB Report began tracking a number of indicators proposed to be related to TB. And as you may see here on the screen, many of which are highly important, but none of which were incarceration. And year after year, incarceration, prisons, etc., anything related to incarceration had not even been named in the Global TB Report until about 2023, when it was finally given an online feature amidst mounting evidence of its significance for TB. To date, though, I'm showing you now the most recent 2024 report, and you can see that incarceration continues to be overlooked and under-recognized as a TB determinant. And so really quantifying the role of incarceration as a TB risk factor is essential to guide strategies and inform resource allocation for TB elimination. So in this study, we set out to do exactly that, to quantify the true impact of incarceration on the TB epidemic in Latin America, accounting for these factors that have led to under-recognition previously. So under-diagnosis in prisons, infections acquired in prisons that progress in the community after release, as well as onward transmission to other community members. And specifically, we had two aims. So first, we wanted to quantify specifically the excess population level TB burden that could be attributed to the rise observed in incarceration rates since 1990. And secondly, we wanted to project the effects of policy alternatives for incarceration on future TB incidents at the population level. So we did this for six diverse countries in Latin America: Argentina, Brazil, Colombia, El Salvador, Mexico, and Peru. And we selected these countries largely based on availability and quality of data on incarceration and TB. But we also sought to ensure regional heterogeneity as well as heterogeneity in incarceration trends and TB epidemiology. So here I'm showing you incarceration rates over time, TB rates in the general population and in prisons, and each line is a different country in Latin America, and the six included countries are shown in color. So you can see they really encompass a wide range of, both carceral characteristics as well as TB epidemiologies, and collectively they represent about 80% of the region's total prison population as well as TB burden. And so for each of these six countries, we developed a mathematical simulation model to really model the dynamics of incarceration and TB spread. So I'll try to walk you through each step of this. But essentially here, we, in our model, all individuals in a population can be represented by their TB state and their incarceration status. And so with regards to TB here in the columns, we have 5 compartments that encompass the range of TB infection and disease. And individuals can essentially transition across these compartments as they are infected and as they develop disease and recover from disease. We then replicate these TB compartments across 4 population strata, 4 incarceration-related population strata. And individuals can also, in addition to traversing across TB compartments, they can also traverse across these population strata as they are incarcerated, as they are released, as they are reincarcerated, etc. And I'll note that we distinguish here between people with recent and distant history of incarceration based on data that the risk of reincarceration, TB, and mortality declines over time after release from prison. And now, then how do we actually, map out the flow of individuals throughout these different compartments and strata? So the rates of transition across both TB compartments and incarceration strata are governed by parameters in our model, which are calibrated and tuned to real-world, country-specific data over time on incarceration and TB. And because of known uncertainty in the real world and uncertainty in our model and assumptions, we had wide uncertainty distributions around both the data targets and our parameters, which are then propagated throughout the model and results. Now, with this model, we can then simulate alternative kind of counterfactual or hypothetical scenarios where we artificially impose changes in a given parameter of interest, for example, incarceration rates. We then can analyze differences in TB rates under each of these scenarios. So I'll walk you through now what we did using that model to create the 2 incarceration scenarios that serve as the foundation for the first half of this project. So here we have a panel for each country, time on the x-axis, and incarceration rate per capita on the y-axis. And the dark blue line here represents the model fit to data on incarceration rates in each country since 1990. And this is what we call the observed scenario. We then wind the model back and simulate an alternative hypothetical scenario, shown here in orange, where there was no increase in incarceration rates since 1990. We can then examine and compare population-level TB rates under each of these incarceration scenarios. So let's start with Brazil as an example. Here again, year on the x-axis, and on the y-axis, we have population TB incidence rates per 100,000. And the blue line now here is the medium model fit to observe data and the data points on TB incidence at the population level. Now, in comparison, in red, we have the estimates for TB incidence under the counterfactual scenario, where incarceration rates remain stable since 1990. And this difference in TB incidence between the 2 incarceration scenarios represents what we call the excess TB that's attributable to the rise in incarceration. If we then set TB incidence under the counterfactual at 0 and just take the difference between these 2 curves, we can then plot that difference or excess burden for each of the 6 countries over time. And you can notice, a wide variability in the magnitude of the excess burden across countries, but nonetheless consistent growth in that excess burden as incarceration rates have increased in each country over time. So next, we wanted to see where these excess cases were occurring. And these are the same plots from the previous slide showing the excess TB burden attributable to the rise in incarceration. But now they're filled in based on where excess cases occurred. So the darkest red color shows cases that occurred in prison and were diagnosed during incarceration. So these are the cases that would have been captured by looking simply at diagnosed and reported cases in prisons. Now, if we go one shade lighter, those are cases that occurred in prison but remained undiagnosed during incarceration. And the next band is then cases arising among people with incarceration history. And the lightest shade are excess cases from onward transmission to people with no incarceration history. And the key takeaway here is that across countries, the TB burden attributable to incarceration far exceeds cases diagnosed in prisons, with a substantial portion of that burden manifesting in the community. And you might have noticed some variation across countries in kind of the distribution of where this excess burden is occurring. And so, for example, in El Salvador and Peru, you might notice that the vast majority of the excess burden occurs within prisons, whether detected or not detected. And this is largely due to these two countries having a longer duration of incarceration, on average 4 to 6 years, in contrast to other countries where the average duration of incarceration is about 1 to 3 years. And in those other countries, more of the incarceration-related burden of TB actually manifests in the community after release. And this suggests the importance of considering incarceration dynamics, especially if and as policies change, as this may affect the relative impact of interventions that target people in prison versus people released from prison versus other people in the community. Okay, so now how does incarceration and how do our estimates for the burden attributable to incarceration compare with those of other TB risk factors that, as you saw earlier, are routinely surveilled and reported by the World Health Organization? So here in blue, we have estimates from the WHO for the percent of all TB cases in 2019 that are attributable to each of these 5 risk factors. And our estimates for incarceration are highlighted in red. In particular, again, the dark red bar, the light red bar represents the crude estimate using only data on cases diagnosed and reported in prisons. And the full red bar are our modeling derived estimates. And you can see that by accounting for under detection in prison and the dynamic nature of incarceration cases that occur in the community, we get estimates for the population attributable fraction that are far greater than previously recognized. And across all these countries, incarceration emerges as a leading, if not the leading, determinant. Collectively across countries, accounting for more than 1 in 4 new TB cases in 2019. All right, so now moving on to AIM2. So how do we address this crisis? The most immediate, obvious counterpart to what I showed you is to intervene on incarceration rates. And so here we simulated future alternative incarceration scenarios and projected their impacts on future population TB incidence in 10 years. And now I'm showing you these future scenarios for Peru as just an example. So here we have time on the x-axis, and now we have incarceration rates per 100,000 on the y-axis. And in the dark blue blackish line here, we have the stable scenario or the reference scenario where incarceration rates, specifically entry and release rates, remain constant for the next 10 years at their current levels. In the purple line here, we have the continuing trend scenario where trends in incarceration from the last 10 years continue for another 10 years. And then we have a number of decarceration scenarios where we reduce incarceration rates by reducing entries by 25% or 50%, duration of incarceration by 25 or 50%, or both entries and duration. And here, I just want to point out this horizontal dashed line represents the incarceration rate in 1990. So you can see even under the most kind of the most significant decarceration scenario, we still have not reversed yet back to 1990 levels. And so then we can estimate, using these scenarios, we can estimate and project what population TB incidence would be in 10 years from now, or in 2034 rather, under each of these scenarios, and compute the percent difference in this population TB rate compared to the reference scenario where incarceration rates remain stable. And just one last note, which is that these interventions or these incarceration scenarios were simulated assuming no other changes to prison conditions, to transmission rates in prisons, nor to diagnosis or treatment in prisons or elsewhere. Okay, so now we have a series of box plots where the dashed vertical line represents the reference or stable scenario. And on the x-axis, we have the percent difference in population TB incidence relative to the reference scenario. So we can see that if incarceration trends from the last 10 years continue for the next 10 years, we can expect to see slight increases or slight decreases in future population TB burden. Now, in contrast, reducing incarceration rates, either by reducing entries or duration or both, could have a significant positive impact on future TB burden. And in particular, you might notice that these percent reductions are largest in countries with the largest TB burden in the region, namely Brazil, Colombia, and Peru. And also to put these reductions in perspective, these are comparable to the projected reductions for Latin America from the introduction and scale up of a hypothetical new effective TB vaccine, which still does not exist, which would be projected to reduce population TB incidence by 16%, or a comprehensive intervention that scales up TB screening and preventive therapy community-wide in Brazil, which would be projected to have an 18% reduction in TB rates. And so these projected effects of incarceration, alternative incarceration policies, exceed or at least are on par with these projected impacts of biomedical interventions. Now, lastly, I want to share our projections for El Salvador. Some of you may know that since March 2022, El Salvador has been under a state of emergency or a regime of exception, where the president, Nayib Bukele, has rounded up tens of thousands of citizens and filled mega prisons with them, such that the prison population has nearly tripled in the matter of a couple of months. And as of last month, the state of emergency was renewed for the third year. And there's been widespread human rights violations and abuses and due process violations reported, and deaths spiking in custody reported since the start of this state of emergency. There's a lot of uncertainty around how this will affect TB, but if you might have remembered, El Salvador was already one of the worst culprits in terms of the population TB burden attributable to incarceration. It was the highest in the region. And we project now, as a result of this state of emergency, a further worsening of this already horrific crisis, such that we project that population TB incidence has doubled since the start of the state of emergency. And this is really going to set back the country and lose decades of potential progress in TB control and prevention. So I want to just share some limitations of our study. Our model did not include age, gender, HIV, MDR TB, drug-resistant TB, or other socioeconomic factors that are likely related to TB and incarceration. Now, some of these, are less likely to be a major factor in Latin America, with the prevalence of HIV being less than 1% in most of these countries in the region, as well as the prevalence of drug-resistant TB being much lower in Latin America than in other regions. However, certainly accounting for these may have swayed our estimates in one direction or the other. We also had, still at the end of the day, limited data to calibrate our model and inform assumptions. We tested a lot of different sensitivity analyses where we varied these model assumptions and had wide ranges of uncertainty intervals for our parameters. And we found that our results did remain generally robust across these different tests. Another limitation is that our changes in incarceration rates, both in the historical and in the future scenarios, were modeled really in isolation from the complex web of upstream drivers and downstream effects. And so, certainly we are kind of simulating a scenario that would be simplistic. And of course, our future projections are subject to great uncertainty. And finally, our results may have limited generalizability to other settings, but I think we can confidently say that what is likely to be the case globally is that the contribution of incarceration to the TB epidemic far exceeds what we currently know or estimate simply based on diagnosed TB cases in prisons. So to summarize this section, we found that decades of rising incarceration rates in Latin America have really undermined TB progress in the region and contributed to an outsized burden of TB that goes far beyond prison walls. And we found that incarceration is now a leading TB driver in the region, with a much larger role than has been previously recognized. And interventions to advance decarceration have potential to substantially reduce population-wide TB and accelerate progress towards TB elimination. Now, in the last few minutes, I just want to share some ongoing preliminary work. Decarceration surely is critical, but optimally, it's also paired with targeted efforts to improve TB care and diagnosis. So, the World Health Organization currently strongly recommends systematic screening for TB in prisons, but it's still not done in most prisons in Latin America. And so we have adapted our model to now simulate a number of different systematic screening interventions for TB in prisons. And here I'm showing you some results for Brazil. So in the left-hand panel, we have TB incidence in prisons, and in the right-hand panel, TB incidence at the population level. And each of the lines represents a different simulated screening intervention. So screening at entry into prison, screening at exit, as well as prison-wide mass screening conducted annually or biannually, or some combination of these. And you can see, this is happening during the period that's represented in the gray shaded area. You can see that we're achieving pretty substantial reductions in TB incidence through many of these screening interventions, predominantly the mass screening interventions, and that they end up having quite substantial effects at the population level. Really suggesting that these screening interventions in prisons should be prioritized as a key strategy for national TB programs in the region to accelerate TB control. And of course, I'll note that, as you can see, as soon as we stop the intervention, we project that TB incidence will bounce right back. And so again, this is simulating screening in the absence of any other intervention. And so again, what we really need is a multi-pronged approach that addresses both kind of the underlying policies, the underlying conditions of incarceration, and seeks to, in a targeted manner, address TB. And there's actually precedent for this in Kazakhstan, where Penal Reform International and the Netherlands Tuberculosis Foundation, KNCV, collaborated to lead comprehensive efforts to address TB in prisons, where they integrated biomedical interventions with decriminalization reforms. And following expansion of the program in 2000, rates of incarceration dropped by 70%, and with it, the rate of TB in prisons by 90%. And so this, really suggests the synergistic potential of biomedical interventions with kind of high-level policy and transformative systems level change. And this is one of our future directions moving forward, to also model this combination of policies to target TB efforts with improvements in prison conditions and reductions in incarceration rates. All right, so with that, I want to thank my fantastic co-authors and collaborators, in particular my PhD advisor, Jason Andrews, and his 10-year-long partnership with Giulio Croda from the Federal University of Mato Grosso do Sul, studying TB in prisons. And during my PhD, I was really fortunate to join this collaboration and learn immensely from it, including several months long stint living in Brazil and working closely with Dr. Croda's team. And for this work, we additionally engaged many wonderful epidemiologists and clinicians and officials from national TB programs in the region, as well as social scientists and criminologists who had expertise on criminal justice and public security in Latin America. And then, of course, also my PhD funding sources. And thank you all for your time and attention.
Thanks so much, Yiran. And thanks again for braving an awful time difference as well and staying up late to give this presentation. I'm going to kind of selfishly steal the first question, I think. And I guess I love this paper. I think it's one of the best examples I've ever seen of sort of prison health as public health. In terms of like the reaction you've gotten afterwards from, I guess, both within the research community and sort of healthcare community more broadly and policy people, what's sort of that been like? And yeah, how's that? Yeah.
Yeah, thank you. So the reaction has been interesting. Certainly, we've gotten interest from researchers. We're now working in collaboration with a team at the London School, where they do a lot of TB modeling, And they have also adapted our model and are now also looking at interventions targeted at prisons or in populations impacted by incarceration more broadly. I think among people in the healthcare sector or even in national TB programs, I think the reception has been, yes, absolutely, TB is a major driver. And, incarceration rates are completely out of our control. And so, I think there is still this inclination to kind of stay squarely in the lane of let's just try to do biomedical interventions. Let's try to promote implementing these screening and treatment programs in prisons as much as we can. And can you now model, part of this modeling that I showed on screening interventions is because as soon as we showed these larger policy results, everyone was like, okay, but can you model screening and can you model preventive therapy? So I do think that there is still that bias for sure, and understandably so. I think, from a broader audience, we've gotten some good coverage. The Guardian covered it. We've been on some podcasts, speaking briefly on it. So I think it has garnered hopefully some coverage for a broader audience. And I think it's definitely a critical time right now to be raising awareness about TB globally and in vulnerable populations and how it's all completely connected.
Yeah, definitely a telling message. Is a lot of Latin America sort of seems to think that Bukele's policy is a good idea. Does anyone else, Stuart, would you like to ask a question?
Yeah, and yeah, thank you so much for that presentation. I'm sorry I had some tech issues, so I was a couple of minutes late, but fascinating. I've got a bunch of questions and things I'm curious to know. I guess if I could pick one, it would be I don't understand the modeling obviously nearly as well as you do, but I suppose my question is, what do we do about this? And it sounds like there's two things. One is reducing incarceration, the other is doing better at picking up cases of TB in custody, obviously, as well as doing things to mitigate the risk of transmission in custody. And so it's a bit of a two-pronged question with respect to the prevention. Is there a risk of people being a bit reductionist about the message here and thinking, well, we just need to reduce incarceration, where if I understand your work correctly, you're saying we need to reduce incarceration and then pick up those cases of TB in the community and do something sensible to reduce the burden in those individuals and reduce their risk of transmission. And then the second half of my long question is, I'm just reflecting on that remarkable thing where you were looking at the reported, but then the modeled estimates of population attributable fraction for TB, or for incarceration, sorry, for TB. And it made me think of the same mistake that WHO seems to be making with respect to Hep C. I just put in chat a paper led by Lara Tavoshi, where WHO not that long ago published their updated Hep C elimination strategy and made no mention of incarceration, which just seems insane to me. So a bit of a rambling question, but I'm really keen to hear your thoughts on all of that.
Yeah, thanks for both questions, and thanks for inviting me to share my work at this wonderful seminar. Yeah, I definitely see where you're coming from and agree. So to that, I'll note, if we decarcerate, we will reduce rates of TB at the population level because we're sending fewer people to prison and keeping them there for less time, and TB rates will naturally go down at the population level. That said, these decarceration interventions, I didn't show this, and it's not even in the paper, but these decarceration interventions will not reduce the rate of TB within prisons. So given that you are still being incarcerated, your risk of TB will be as high as it ever has been, because we didn't model, I should say, we didn't assume that decarceration would automatically, on its own, lead to a reduction in the risk of TB once incarcerated. It may be that that's the case, but it also may not be true. Governments might close prisons and keep people in similarly overcrowded conditions as they decarcerate. And so I completely agree that we need to pursue these efforts alongside one another to reduce exposure to incarceration and make sure that people who have been in prison and who are in prison now and who will still be in prison in the near term get all access to diagnostics and treatment and all the care that they need and deserve. And then to your second question for Hep C, yes, absolutely. I have actually seen some modeling done similarly. So, you know, when we were in the early stages of this, actually, I think we saw some papers using similar tools, similar methods, mathematical dynamic transmission modeling to estimate these transmission population attributable fractions for HCV and maybe even HIV as it pertains, at least I think it was for unstable housing. And then maybe also in some places incarceration or drug policy or something like that. I'm blanking on the team that's leading it right now, but I believe there has been some work done in the Hep C space on this as well. But you know, I'm not surprised that that has not yet been acknowledged by the WHO.
Thank you.
Not that I want to be really criticizing the WHO in this moment. Also,
Yeah,
they do important work, and we need to continue supporting them.
Yeah, it's Jackie Short here. Look, I'm forensic psychiatry over in New Zealand. That was a great presentation. Thank you very much. And my question to you is, I mean, the rates of TB that you showed us in Latin America. I mean, I was gobsmacked because I have, to be honest with you, absolutely no idea about those rates in Latin America. But my thinking is that for those countries that have hugely elevated rates of TB, and as we know, you know, TB is depending on where you are in the world on the increase as well. Mental illness in prison is extremely common, and we know that depression and schizophrenia, for example, are related to an increased incidence of TB. So I'm wondering if going forward for those countries that have got this, you know, overwhelming problem, and you know, here in New Zealand we're very fortunate with our incidence of TB is really quite low. But I'm thinking those countries, psychiatrists and psychologists, but psychiatrists going into prisons, doing clinics, seeing people with schizophrenia, seeing people with, you know, depression, chronic mental illnesses, etc. Whether in our routine screening that we do, should we be including screening for TB as well?
Yeah, it's a really interesting question. And I think perhaps, you know, I'm not as well versed on the prevalence of mental illness in prisons in Brazil or elsewhere in Latin America. I do believe that it's likely different from what I imagine it might be in New Zealand, certainly different from what it's like in the US. That said, absolutely, you know, there are these subgroups or subpopulations within the incarcerated population that are likely at elevated risk, even more elevated risk for TB due to these kind of other risk factors, coinciding risk factors. I think whether or not it's worth doing screening likely depends on the expected yield and also, you know, projected kind of impacts and costs from investing really heavily and universally in a program like that. I think if it's projected to have health benefits, then it's absolutely something worth considering. But I think we would probably need some empirical studies on that. I'm not sure. I don't know too much about that literature to target that population specifically within the prison setting. I do know from our collaborators in other countries and other regions, they have found that actually people who have already been diagnosed with TB and who have co-occurring substance use disorders, starting those folks on treatment for substance use disorders actually improves their chance of completing TB treatment. So certainly there's definitely this overlap and interaction there. But I don't know if I can answer well the question of, should we be additionally screening for TB? I think we could certainly take a look at that. Thanks for the question.
Sure.
I told you I had a whole lot, Yiran. I'm sorry, your brain must be starting to crash at this time of night, but thank you for sticking with us. Look, I'm just wondering, I'm again fixated on the difference between the observed and the modeled population attributable fraction. And it suggests, not surprisingly, massive underascertainment of TB and probably a lot of other health conditions, which I think is what we were talking about just before. Anyway, so it leads me to the WHO, among other things, has been doing a collection called the Health and Prisons European Database, which is collating data on the health of people in prisons in the European region with aspirations to go more broadly. But the problem is the quality of the data. And so I'm wondering, this is kind of a combination of a technical and an epidemiological kind of utility question. Should they be thinking about using modeled estimates and presenting both the observed and the model? Because, for example, let me just give you an example. Out of 63 countries, I think, they had 3 countries that reported on diabetes, and so it's better for HIV and a few other conditions. But it looks to me like, to the extent that your modeled estimates are quite robust, and they seem to be, in addition to the observed prevalence, it might be useful to do that. I'm wondering if you have any thoughts on the use of these methods in a kind of a surveillance context.
Yeah. It's a really good question. I think absolutely in the context of gaps in data, it can be helpful to model to try to extrapolate from what data we do have to generate better estimates, especially if something like underdetection is suspected. I think it might depend on the condition of interest and also the hypothesized mechanism through which incarceration is likely to affect that disease. So, for something like diabetes, I would, again, I'm not a physician and I'm not a diabetes researcher, but I would posit that incarceration is not as strong of a causal factor in diabetes incidence as it is in TB incidence. It's pretty clear from all the work that we've done empirically and more analytically that like the high risk of TB in these prisons that we're working in is almost entirely due to the experience of incarceration. I don't think I could say that about diabetes. Certainly it might be exacerbated by incarceration. There might be challenges in continuity of care and management of the disease after release and whatnot, but I don't know what the extent or the magnitude of that causal relationship. So I would suspect less that there's going to be as much of a discrepancy between maybe what we see in the data versus what we would expect to see in a modeled estimate. I think that's kind of the nature of infectious versus non-communicable diseases. I think we would expect kind of similar trends as what we found here for other communicable diseases. Although, again, TB is unique in that it's such a slow infection, and that also combines with this dynamic of incarceration and release. Because TB can take months to years to progress, it really is this thing that you need to be able to follow people after release and track their cases after release to get this full picture. That might not be the case as much for something like COVID that actually spreads much faster and progresses much faster.